If a root canal preparation goes too deep, it shreds sensitive periapical tissue. If it stops too short, infected pulp remains behind, allowing bacteria to multiply and eventually sabotage the entire procedure. To succeed, you have to hit a microscopic, invisible target, the apical constriction, also known as the cemento-dentinal junction. This is where the root canal pinches inward before opening out to the surrounding tissue. In most patients, this critical junction sits approximately 0.5 to 1 millimeter short of the anatomical apex. For decades, dentists tried to feel for this drop-off using tactile sensation alone. But as this chart illustrates, relying purely on touch results in a 67% non-acceptable agreement rate with the actual working length. To replace this subjective guessing game, we have to adopt a specific step-by-step protocol using modern electronic and radiographic tools to secure a verified data point. Step 1 takes place before you even turn on a measuring device. You must scout for patency and aggressively pre-flare the coronal third of the canal. Without pre-flaring, tight cervical constraints will physically bind the file. This creates false resistance at the top of the tooth, making it impossible to accurately feel or measure what is happening down at the apex. Once you have straight-line access, select an ISO standard manual K file to take your measurement. The accuracy of an electronic apex locator depends heavily on this choice. The file diameter must closely match the width of the major apical foramen. If you use an undersized file in a wide canal, the metal tip floats loosely. Without consistent wall contact, the electrical circuit breaks. To fix this, switch to a thicker file until you feel a snug engagement at the apical terminus, completing the circuit. Proper mechanical preparation and exact file sizing are absolute requirements. Without them, your electronic measuring devices are operating completely blind. Now that the physical space is prepped, we have to control the electrochemical environment. Modern multi-frequency apex locators require a specific setup: dry on top, moist on the bottom. Take a cotton pellet and thoroughly dry the upper pulp chamber, but deliberately leave the lower root canal moistened with your irrigant. If the pulp chamber is completely flooded, the electrical current can jump across the fluid and hit a metallic crown or amalgam filling. This creates an immediate short circuit and triggers an instant false reading on your device. You also have to watch your chemistry. High concentrations of sodium hypochlorite, like a 5.25% solution, are highly electroconductive and will severely distort the accuracy of your readings. Managing these invisible variables, the moisture levels and the chemical conductivity, is just as vital as shaping the physical anatomy. With the environment optimized, attach your file clip. Make sure the lip clip is well moistened to complete the external circuit. If the patient has a dry mouth, wrap the clip in wet gauze. Next, we apply the advance and retract technique. Instead of stopping exactly where you think the constriction is, carefully push the file past the target. Advance the instrument until the locator display reads 0.0 or apex. This indicates the file is just tickling the periodontal ligament. From there, slowly pull the file back until the screen hits the 0.5 mark. This locks your measurement precisely at the apical constriction. This pie chart breaks down the accuracy of the electronic method using the Root ZX Mini. Combining the 40% exact agreement with the 50% acceptable agreement yields a highly reliable 90% success rate. There is, however, one major anatomical variable that will throw off a perfect reading: a root canal with a curvature greater than 20 degrees. As you run instruments through a severe curve, the canal wall is shaved down, and the physical path length actually shortens. If you rely on your initial measurement, your working length is now too long, and you risk pushing material out the apex. Working length isn't a static number you write down once and forget. It is a dynamic measurement that you must aggressively re-verify as the geometry of the tooth changes. This brings us to the final non-negotiable step: verifying your dynamic electronic reading with a digital radiograph while the file remains seated in the canal. On the X-ray, evaluate the position of the file tip. It should appear exactly 0.5 to 1 millimeter short of the radiographic apex. Pay special attention to maxillary molar roots. Because these roots project very close to the sinus cavity, the anatomy can distort electrical impedance, making this radiographic backup your primary defense against over-instrumentation. By pre-flaring the coronal third, strictly managing the moisture, applying the advance and retract technique, And backing it up with a final radiograph, you remove the guesswork. You secure the exact working length needed to deliver a biologically sound, highly predictable root canal.